Okay, I think we're going to start again. So thank you very much for those of you that are in the room. If we'll give it another second for folks to please sit down. This is a very important part of our PACHA meeting, which is public comment. I'm going to pass it over to Kay.
Great, thank you so much. And this is the public comment period. And most of our public comments are virtual. And then the very last one is supposed to be in person. So I will state your name, title, and affiliation, and then you have 3 minutes for your public comment. I'm going to start with Michael Bailey, President and CEO of Compass Housing Alliance. Michael, the floor is yours.
All right, I've got
and I think
video.
Perfect. Yes,
okay.
hi,
Do I
Michael.
have sound? Awesome. Hey, can folks hear me?
Yes.
Yes. Okay, perfect. Good afternoon to the members of PACHA. Just want to thank you for allowing me the opportunity to join you virtually. I was actually hoping to join in person, but we had some activity at the state capitol today, and I didn't want to miss out on an opportunity to advocate for our service population. That said, my name is Michael Bailey, and I have the pleasure and privilege of serving as the president and CEO of Compass Housing. I'm also a state commissioner on the state's medical board. As it relates to Compass Housing, we're a housing nonprofit. We're based in Seattle, Washington. We operate around 700 plus units of affordable housing, around 300 shelter beds across 20 sites. And just for a little bit more information, the Medical Commission is essentially a licensing and regulatory agency dedicated to protecting the patient population across the state. We prevent discrimination, malpractice, and any ethical violations by either licensed physicians or nurse practitioners. I joined Compass after several careers with state government. I worked with state of South Carolina, worked with state of Georgia, state of Washington, but joined Compass because I believe there's certain fundamental rights that no person should have to fight for. And for me, access to quality and culturally appropriate healthcare and access to housing are two of those things that we're fighting for here in Washington. I understand that PACHA exists to advise the Secretary of Health and Human Services on the treatment and prevention and the cure of HIV and AIDS. And as you execute that responsibility, I just ask that you remember the unsheltered population, but also those struggling with housing insecurity. You know, the 20 plus facilities that I referenced above, you know, those are instrumental in providing some of the much needed support and resources to both those populations. And our population tends to include individuals living with HIV and AIDS. And as you're likely aware, you know, that population, because they're homeless or because they're unstably housed, they tend to have a harder time attaining or sustaining care, at least compared to those with more stable housing. And, you know, I'm listening to the amazing panel that you folks had, and thank you so much for convening that. And I think Daniel made a really good point about, you know, the individuals that we're serving tend to be less trusting of some of the more traditional structures, some of those government-led social work and healthcare programs. And there's really a timely opportunity to empower and really leverage our frontline employees, you know, because these are the trusted messengers. These are the folks that can actually help someone through the process of not just getting housed, but, you know, getting health insurance, pursuing care, and also following up with their care plan. So just really asking for you to allow us a voice as you do the work that you've been entrusted to do. You know, it's not just the unsheltered population or the housing insecure population, but it's also the workforce supporting those two populations. And, you know, Paul, you know, prior to you going to break, really made that statement about the pivotal moment where funding may be in jeopardy, you know, depending on where the political winds may blow. And I will be transparent in saying that I've served under Democratic governors, I've served under Republican governors, and to kind of answer Paul's question, not that he needs me to do so, but you know, how do you provide critique in a way that isn't taken offensively or, you know, takes away from the opportunity to make a meaningful difference? And you do that through process. You do that by requiring community to be a part of the process. Yes.
Yes, I know you're midstream there, but I do want to honor, we have other public commenters.
Yes.
And it's a 3-minute time, and we've allowed a little grace and you've gone beyond, but I do want to be respectful of the others.
So sorry.
No
Yes.
worries. No worries.
Yeah,
So if
just
you
want
want
to
to
wrap up
take
and
10
yeah,
seconds, you got it. Thank you.
awesome. Thank you. I should have set a timer on my side. Yeah, everything I'm sharing you've heard throughout today's conversation. In closing, I just want to ask to be a part of the conversation, include the housing community as part of that conversation. And I also want to say thank you. Thank you for your courage. Thank you for taking the time to fight the battles of others. And my hope is that in a future state, this body can remove the need to even have to fight. So thank you for the time and thank you for all that you do.
Wonderful. Thank you, Michael, and thank you for your comments.
Thank you.
Our next public comment is from Mario Harper, Director of the U.S. Business Action to End HIV. Mario, the floor is yours.
Thank you so much, Kay. It's great to see you. Distinguished members of PACHA, thank you so much for the opportunity to speak before you today. My name is Mario Harper, and I'm proud to represent the Health Action Alliance and our U.S. Business Action to End HIV initiative. We are a coalition of private sector companies united by a common commitment to end the HIV epidemic here in the U.S. I want to first acknowledge the members of PACHA who helped inspire this vision for this coalition. Nearly 2.5 years ago, PACHA co-chairs Marlene McNeese and John Wiseman sent a letter to HHS outlining the need for an initiative that engaged the private sector in our nation's effort to end HIV. This call to action resonated with ViV Healthcare, who reached out to our team at HAA to see if we could help turn this vision into a reality. Just over a year after launching, the coalition has since grown to 43 companies, anchored by several major employers and brands. The mission of the coalition is aligned with the National HIV and AIDS Strategy, which is to accelerate that progress in ending our nation's HIV epidemic and improve health equity across the country. The success of the coalition is rooted in the collective actions of our members, from hosting HIV education events and strengthening HIV health benefits for employees, to launching new innovative partnerships and connecting customers and vulnerable communities with HIV services. Our member companies have taken a range of impactful steps to address the epidemic. And we're so proud of those steps. And we're also proud to offer additional programs that deepen this business engagement as well. Our industry action cohorts bring together industries or specific roles within companies that can have a unique impact on HIV. And we're also developing local chapters in priority regions to better engage businesses in the local public health response. We launched our first local chapter in Atlanta and are excited to be developing our second chapter here in Houston, actually, working closely with Ms. Marlene McNeese and other local leaders to identify the unique needs of this community and how Houston businesses can be a force multiplier of public sector efforts. We're thrilled to be working closely with the Houston LGBTQ+ Chamber of Commerce and Mercer as we look to launch the Houston chapter later this summer. Our newest coalition member, Chevron, is also excited to be a leader in this local effort, so we're really proud of that. We also look for opportunities that can benefit from the collective voice of the private sector. So last month, the coalition spearheaded the submission of a letter to Congress, signed by influential private sector leaders, calling on Congress to fully fund domestic HIV programs in the final 2024 appropriations packages. We believe the private sector can really be a catalyst for achieving the ambitious goals outlined in the National HIV and AIDS Strategy. And we're not here to replace any existing efforts, but our goal is simply to collaborate. We stand ready to work alongside this esteemed council and other stakeholders, and we know that together, through collective action and these innovative partnerships, we will continue to work to create healthier workforces and community. And I thank all of you for your time.
Thank you so much, Mario. Our next public comment comes from Carl Schmidt, Executive Director of the HIV and Hepatitis Policy Institute. And while it's not on my paper, he's also our former PACHA co-chair. Carl, the floor is yours.
Well, thank you, Kay. Good afternoon, everyone. So today we'd like to focus on something that actually co-chair Marlene McNeese actually first raised at a previous PACHA meeting, and she actually referenced it this morning. And that is the substandard HIV drug coverage by one of the insurers in Houston, Community Health Choice of Texas. We all know the importance and value of modern day HIV treatment, including single tablet regimens, using the most current drugs that do not cause serious side effects, our drug resistance, the value of NIH's treatment guidelines, and the importance of adherence, which all lead to viral suppression. And we also know that high cost sharing leads to patients not taking their drugs. We are also very thankful to the patient protections enshrined in the Affordable Care Act. This includes important non-discrimination provisions and implementing regulations. Plans cannot place all or a majority of their drugs to treat a specific condition on the highest cost-sharing tier. Drug formularies must be clinically based and follow acceptable treatment guidelines. A plan is potentially discriminatory if it does not cover single tablet regimens. So we took a look at Community Health Choice and found some troubling results. We then filed a complaint with CSIA, which is the federal agency that regulates ACA plans in Texas. I know today you talked about a lot of the challenges, the local challenges in Texas, but on this one, the enforcement rests with the federal government. We found that some of the drugs on its formulary are no longer used and phased out due to their high toxicity levels. One of their plans does not cover a single drug recommended to initiate therapy on NIH's HIV treatment guidelines. Another plan just covers 3, but 2 of them have to be taken as 3 separate pills. Very few single tablet regimens are covered. One plan puts all HIV drugs on the highest tier, while another one puts 68% of them on the highest tier, which can translate into 50% coinsurance. We compiled all the plan data, the treatment guidelines, our analysis, along with the government's own regulations, and included it in a formal complaint. Unfortunately, we received a disappointing response that, while acknowledging some of our concerns, sadly gave a pass to the insurer and did not seem interested in enforcing their own regulations. Exposing the plan must have had some impact, because we found out just this week that their March formulary shifted some drugs away from the high-cost specialty tier, but there was no change in what drugs were covered and not covered. We're now working on scheduling a meeting with CSIA with advocates and providers from Houston to further discuss their response and lack of enforcement. We hope you share our concern that if the federal government allows this plan to get away with this, other insurers will follow suit and could jeopardize HIV treatment around the country. Thank you very much.
Thank you, Carl. Our next public comment is from Jason Farley, Endowed Professor of Nursing Leadership and Innovation, Johns Hopkins School of Nursing. Jason, the floor is yours.
Hello, everyone from South Africa. Dear esteemed PACHA members and federal leaders, my name is Dr. Jason Farley, and I'm an HIV primary care nurse practitioner, a research scientist, and a professor at the Johns Hopkins University, where I direct the Center for Infectious Disease and Nursing Innovation, also known as CIDNI. On behalf of CIDNI, I'm thankful to speak before this esteemed body to address our concerns for the reduction or withdrawal of funding for the Ending the HIV Epidemic initiative. CIDNI receives funding through all 4 pillars of EHE to support the people of Baltimore City. For time, I will speak about 2 of these today. Under the Diagnose pillar, our testing efforts seek to offer status-neutral approaches for HIV testing. Linkage and navigation services for PrEP or HIV care are offered to every client in English and Spanish. Recently, the Baltimore City Health Department learned that funding would end in early July of 2024, and new CDC funding opportunities are now delayed due to Congress's slow action on budget appropriations. This is a clear threat to public health and EHE progress. Now that a new budget is moving forward, we must also recognize that flat funding equates to a reduction in HIV funding. Under the TREAT pillar, our HRSA-funded, nurse-led community health worker model seeks to offer an unapologetically enabling intervention in support of people with HIV who struggle with viral suppression. Despite the amazing Ryan White model of care, approximately 10 to 15% of Ryan White patients are unable to achieve or maintain viral suppression. Unfortunately, mental health, substance use, and the social and structural determinants of health are all too often the prevailing reasons why. I wish I had time to share with you some of the amazingly powerful stories, but I will say that under this program, 70% of clients have now achieved viral suppression, and 43% of those have sustained viral suppression for 6 months or more. Now, of those 70%, I'm speaking about the 10 to 15% who remain at the margin, who are not routinely virally suppressed. So to find 70% of those clients virally suppressed, that's a remarkable achievement. But this HRSA-funded program, however, recently received notice that funding was dependent on congressional budgetary appropriations, and a partial funding award covering only 6 months of this year's budget was awarded. Congress's inaction again threatens delicate progress. I call upon PACHA to prepare a resolution to Secretary Bakara outlining the successes of the EHE program and the harmful national impact either a reduction or withdrawal of funding will have. I want to emphasize again, continued flat funding of HIV efforts translates into a reduction of programmatically available funding. To effectively end HIV in the United States, EHE should not only continue, but funding for this initiative should be increased, and your resolution should utilize EHE programmatic successes to justify increasing available funding. In closing, I want to thank you all again for your time and for your service to the American people. Thank you.
Thank you, Jason. Our next public comment is from Jester Jersey, a Vaccination Collaborative, Vaccine Your Family, a community health worker and vaccine health advocate. Jester, the floor is yours.
Thank you. Good evening to the Presidential Advisory Council on HIV/AIDS. My name is Jester Jersey, and I'm a vaccine advocate serving as a community health worker and health advocate in California and nationwide. I thank the Council for allowing me to speak. The pandemic exposed inequalities for many disadvantaged and stigmatized groups, such as newly arrived immigrants, minorities, the elderly, and those from low economic backgrounds. Even more so for those who are members within several levels of these demographics. Members of the LGBTQI+ community are no exception. When COVID vaccines first became available, some counties in Southern California made access difficult for individuals with HIV/AIDS. HIV-positive individuals who were already using a treatment program like PrEP were prioritized. When Mpox later emerged and guidelines became available for it, the guidelines and information were often confusing, such as where to get vaccines or who was eligible. In both cases, the response could have been better. I've heard similar stories across the country where such disparities happen, but was surprised to hear it happening in California. As a vaccine advocate and fellow member of the LGBTQI+ community, I find this very disappointing. Growing up in the Bay Area in California for most of my life, I couldn't imagine the health inequalities LGBTQI+ community members were facing across the country. At a time when health resources were stretched to their breaking points and trust in the science waning, the last thing we need was to deny care or release confusing guidelines to the LGBTQ+ population. Our nation's health leaders should do better. Individuals with HIV/AIDS are already susceptible to other illnesses. With vaccine rates continuing to remain low for many vaccine-preventable diseases, as well as incidence of measles, tuberculosis, and other illnesses on the rise, we need solutions that inform and empower, rather than guidelines that confuse people at best or ostracize them at worst. Continuing down this path will not only drive down vaccine rates, but also the trust in the science that is supposed to be keeping us safe. We need to invest more in trusted messaging, in vaccine advocacy and disease prevention. We also need to be more proactive instead of being reactive, treating problems at the source rather than waiting for an issue to develop. An ounce of prevention is worth a pound of cure, as they often say. Finally, if we're going to be working towards ending the HIV epidemic in the United States, we need to be more inclusive of those we're trying to help, i.e. give those we're helping a greater say in the efforts rather than prescribing an all-size-fits approach. I've spoken to other government health leaders about this important strategy because all of us in the LGBTQI+ community are uniquely different individuals and deserve care based on our own unique circumstances. I implore the Presidential Advisory Council on HIV/AIDS, the Department of Health and Human Services, and President Joe Biden's administration to invest more in trusted messaging, to collaborate more with health advocates in the LGBTQI+ community spaces, and to provide better care for LGBTQI+ community members across the country. Once again, thank you to PACHA for all the work that you're doing. Thank you.
Thank you so much, Jester. Our next public comment is in person. Selena Harbor, Outreach Coordinator, Positive Women's Network. All right. Selena, the floor is yours.
Thank you, Chair, and members of PACHA for this opportunity to provide public comment. My name is Selena Harbor. I am the Community Outreach Coordinator for Positive Women's Network, Greater Houston area. Today, I would like to talk about the issue of surveillance of trans and gender diverse Texans, and of course, molecular HIV surveillance of Texans living with HIV. The thread connecting all of my concerns is that when health and healthcare are criminalized, whether it is gender affirming care of HIV, surveillance practice can be put us in harm's way, especially for communities who are already over surveilled in police communities. Over the summer, a law went into effect that bans transgender youth from accessing gender-affirming care such as puberty blockers and hormone therapy. Since then, Texas Attorney General Ken Paxton has been requesting medical records on Texas youth from out-of-state care facilities they may have received telehealth services from, including in Georgia and Washington. Gender-affirming care has been proven to be life-saving for transgender youth as they face higher rates of suicide and suicide attempts than their cisgender counterparts. The surveillance of young trans bodies is a violation of patient privacy, human rights, and it must end. While I do not have time to discuss abortion, I do want to bring it up to state that the surveillance and criminalization involved with abortion in Texas is a violation of our human rights. Lastly, people living with HIV in Texas are under surveillance. There are currently over 100,000 people living with HIV in the state of Texas, making Texas the state with the fourth highest prevalence of HIV in the U.S. We are being surveilled through a practice called molecular HIV surveillance, or MHS. In 2018, the CDC began requiring that all states accepting HIV prevention funds must implement MHH, which is the practice that state and local health departments like the Texas Department of Health and Human Services and the CDC use to identify HIV transmission networks by mapping the social and sexual networks of people living with HIV without requiring their knowledge or consent. We are concerned about the lack of consent for people living with HIV. We are also concerned about HIV criminalization, as we are unsure about the possibility that our private health information could be used in criminal prosecutions. This risk is even higher for communities most impacted by HIV and communities most overpoliced, including Black and brown people, queer and trans people, sex workers, low-income, houseless folks, and people who use drugs. The practice of MHS is dangerous. Medical mistrust continues to fracture relationships between our healthcare system and patients most in need of access to care. Sharing folks' information without our consent or knowledge only further deepens medical mistrust and alienates folks from the life-saving medical care they need. On a personal level, I feel that surveillance persists for people living with HIV in many different areas of our lives. I've been living with HIV for 20 years. And for the past 5 years, I have felt unsafe with my medical information in regard to my housing. I utilize the HOPPA program for housing, and every year I must recertify. When I recertify, I'm asked to turn in proof of my CD4 count and my viral load. This is concerning because I'm not sure who else is accessing my private health information without my permission. I cannot trust that my information would not be used against me in a criminal or civil proceeding. This type of mistrust in HIV service programs sustains HIV stigma, which leads to folks not feeling safe to access the care and services they need to thrive with HIV. I am demanding robust health data privacy protections, transparency, and informed consent when it comes to the needs of people living with HIV.
Hi, Celinda.
Thank you, PACHA, for allowing me to be here today to provide public comment on the issues that are important to me.
Perfect. Thank you so much. That concludes our public comment period. I'll turn the floor back over to our co-chairs.
Thank you very much, Kay. So just another round of applause for all of our public commenters. Thank you. So I want to maybe just take the next 15 minutes or so to have some immediate reflections from today and then pass it over to Marlene, co-chair, and then open it up to PACHA members. Marlene, you used a word earlier today. You said full, that you felt very full. I feel very full from today's meeting in terms of the impact. This morning, we started with a great update from Dr. Harrison on syphilis and the national response. I felt honored and proud to be a member of PACHA and saw the impact that PACHA has in terms of national response. We then went to work groups and really thinking about the work that is happening in the work groups, whether it be around the workforce and what's happening in the EHE work group, whether it's in our HIV and aging group and some of the work that's forthcoming around the Medicare program and the opportunities there. I think it was really helpful to hear more about stigma and some of the ways that Leo and Rania and the committee are thinking about how can we better conceptualize and intervene around stigma. And then Patrick and Jen on PEPFAR and the importance of PEPFAR, particularly as it pertains to national response. Fantastic panel in terms of cisgender women and PrEP and some of the invisibility and how we can do better, how we can do more. And then for reasons that I've stated, what I thought was a fantastic session on the Latino community, both the US born and foreign born. Throughout the day, I was heavily impacted by local context. And I think that that local context serves as an important reminder to something that Dr. Wheeler sort of helped us to see, which is that we have a responsibility to think about our nation. And I want to emphasize, Kay, your words were, they're sort of a really important reminder. So I'm going to articulate this again, that I personally, as a co-chair, and I think I speak for many of us in the room who are on PACHA, that our work is to really solidify in our work groups the specific recommendations and the specific ways that we can advance and provide guidance to Secretary Becerra and our federal partners. We have to take that work seriously, and I feel after today much more, I feel charged about doing that work, and I love the passion, Paul, that you articulated in your comments, and I see the locus of that work being back on us. And so thank you very much, Marlene.
Thanks, Vincent. I just want to say, let's go. Let's go. We can't assume that we've come so far in the 4 decades of the response and the work to HIV in this country. When we hear stories from our front lines, like we've heard both yesterday and today, we have pockets of our very important and vulnerable communities who will deny themselves necessary medical care simply for fear of being violated, targeted, ostracized, enforced, criminalized. So I do think there is something for us to be reminded about that this is what we heard, not just a moment that we feel moved in the moment, but that we must, as Vincent described, take serious note and challenge with the work before us to do. Things must change. We must have a different approach. So I am looking forward to what comes out of our strategic planning session. Thank you to the community members, those of you who are here in Houston and throughout the state of Texas. Thank you. I know many of you have traveled far and wide, and I don't know, I haven't gotten counts or numbers, but this may be the most well-attended PACHA meeting I have been to since I have been co-chair. And so I really thank you for your sacrifice of time, your sacrifice of energy, and all that you continue to do for your communities. We needed to hear from you today, so I just had to thank you. And lastly, I'll just thank Ms. Kay Hayes. And all of the staff who work with the HHS Office of Infectious Disease and Policy. They support us in ways that sometimes it's hard to even articulate. They take care of us, and we've had a large contingency travel here to Houston to hear about Texas challenges, and they do a mighty, mighty job. So I'd be remiss if I didn't thank them. And then, of course, our technical support team, Rosalie and Associates, HHS Studios, HIV.gov. They have been working just as hard as we have around this table, and you don't often see them, and they don't get recognized or get the appropriate credit. So thank you for all that you do, because without you, we couldn't hear the important voices of community. And then lastly, for my PACHA colleagues, my PACHA members, I thank you. It is a lot to ask of you in terms of your stamina and your sacrifice to come here. And for a lot of you, it will be an extended week. But I hope you feel how necessary it was to hear about Texas, to feel it and see it and experience it in a new way, maybe a different way in which you've never heard or experienced it before. So that was my mission for putting the plea on the table, and you answered that call. So thank you to all of you for coming. I think with that said, we do have a few minutes for some reflections from colleagues around the table. Go ahead, Mackenzie.
Yes, wonderful. Thank you, Marlene. Thank you, Vincent. Thank you, everyone. I thought today was awesome, and I'm feeling hyped. Two sets of specific suggestions that I thought were fantastic during the day that I wanted to highlight and bring forward, and I might mention them tomorrow in the wrap-up as well, because I think we should move forward in the subcommittee with them, were from Dr. Giordano, who said, what can we do in order to help them and help the people? He said, make it easier to stay on Medicaid, make it easier to stay on Ryan White, and assign EHE funds according to state need, more for those without Medicaid expansion. And of course, that third one, maybe we'd have to, there are probably a few more laws around it. But I loved those. I thought they were super specific and actionable, which are thematic and share a theme with the three suggestions that Paul made near the end of last session, which looked at the RFP process. All of this and everything moves with the money. It's like critical, it's like that's like the one common theme that everybody has. We need money because we have the great intentions, but we need money so we can get lifeblood in order to serve the people properly and well. So I loved Paul's ideas, and I just wanted to highlight them about looking at how the RFPs are written, looking at how they're reviewed, and then also removing or alleviating the requirement for financial infrastructure of organizations, which I think is critical if we're going to get smaller organizations, which are usually newer and usually have more innovative ideas, just because they probably saw some problem, they got hyped, and they wanted to go fix it. And that's where innovation comes from a lot of times. So thank you, everybody, for a wonderful day one, and I'm excited for day two as well.
Thank you. PACHA member Rania.
I put my tent down because I was like, maybe this is just a comment that I can tell Marlene in her ear later. But I just want to really kind of highlight the point that PACHA coming into a city is such a different experience from being in a city. I think I've probably been to Houston, I think more than 10 times in the past decade for work, and been here very regularly. But the experience that I've had just today surmounts a decade of experience and being in the city. And so, PACHA to the people, and I think we say it all the time, but I feel like it's so important to say, especially when we're in a place where funding is regularly threatened, to talk about the importance of PACHA being able to go to different spaces and places, and being able to recognize what it means when PACHA can come into a place. And so for that, I'm very grateful. And at least for me, some of the themes that I'm thinking about are, one of the things I think feels different to me, this is my first time being back in Texas like this after EHE. And it feels different. And it sounds different. And I wonder, as PACHA, I know we have an EHE subcommittee, but what that means, and is there a place and space for PACHA as we are now at this 5-year mark of the innovation of EHE, for us to have some type of response? And that's a question I have for us as a group, especially in such an important year that we're in. What is the kind of recommendations that we have related to that? The other thing that I took away even more greatly than I came into the day with is the necessity for how we think about and what recommendations we might have as it relates to cis women and HIV, that we know that Black women are a priority population when it comes to EHE, but it doesn't look like it's showing up in the programming that's happening. And so what are the things that PACHA might we be able to do related to that, are some of the things that are on my mind, and that I think as we go into tomorrow, and for sure the co-chairs or the chair's strategic session on Friday, thinking about how we action some of this.
Thank you, Rania. Jesse Mylan.
Thank you for a magnificent day. And Marlene, thank you for your vision to bring us to Texas, because it has been eye-opening. In the last 13 or 14 months, states have done some real damage. And I think we heard from Benton how Benton at the state legislature is trying to move the needle forward in Texas. But 13, 14 months ago, the governor of Tennessee decided that he was going to eliminate all CDC funding for prevention. I know that when I got this letter appointing me to PACHA, I was very proud that President Joe Biden appointed me to PACHA. We are the Presidential Advisory Council for the Biden-Harris administration, and we only have 9 more months, and we do not know whether this council or its members will be here in January. We have got to move more quickly on whatever it is we need to do. RFPs, yes, it's really important, but there might be both carrots and sticks that we can use right now in cooperative agreements that have come from the federal government that can help us tell these state legislators and these state departments of health that it is no longer acceptable that Ryan White money is not being used to buy private health insurance for people who need it today. And if our bodies and our committees do not make that recommendation before we leave here, we are wasting our time. If we do not do something about the 29 states that still have criminalization laws, the federal government has the opportunity with a carrot and a stick with these billions of dollars that we are sending to states to say this is no longer acceptable, and we can't simply wait for the Repeal Criminalization Act to be passed by Congress because it's been introduced for 10 years. It is time for us to move quickly in whatever we need to do in order to make it possible for these 12 states that do not have a Medicaid expansion, and these 29 states that still have criminal laws, to get them off the books and move forward to help our people. What we have heard today is Texas is not going to move unless it is made to move. And unless our people, and we can support Vinton and all that the Equality Federation is doing, we are doing that from all of the outside, but on the inside, what we've heard from Paul and others is that we need to use the resources we have in the federal government right now. And I'm telling both Laura and Robin, we may need to hear from you what's possible. What's possible for us to do with existing structures quickly before it's too late? Because January 6th of next year is coming.
Marvell and then Tori.
Jesse, thank you so much for that call of urgency. My palms start sweating because I feel the urgency of your comment. I wanted to acknowledge Elena Ferguson, that we are looking at molecular surveillance. We are looking at HIV criminalization, particularly across the South. So I wanted to say that our committee is on task. And just wanted to provide an update that this council, this advisory body is reviewing that, and we hope to provide recommendations to this body at our next meeting.
Thank you for acknowledging my card that I put down. So one of the things that really stuck out to me was a comment from Dr. Fanfare when she used the term social marketing. And I thought about how, when it comes to PrEP for women in particular, and perhaps even for Hispanic populations and for Black people, we had a social marketing problem and still continue to. And I think PrEP could have been, and could be in the future much more effective if we had a different name for it. You know, in Black communities, when someone was if the doctor said you had diabetes, you tell your children you had sugar. They understood what that meant. They understood what it meant, and they understood what it means and what needed to go into that. And so I think as we move forward, when we think about prevention modalities, and even in terms of how we, the words that we frame around ending the HIV epidemic, I think it perhaps is time for us to come up with new words that reflect more of what the community first understands and wants us to use. And my other response is what I didn't hear very much today is about reentry programs and how effective reentry programs could be and should be, not only in the prevention of HIV acquisition and getting folks connected to PrEP and PrEP services, but also in re-engaging folks in HIV care. So I'm hoping that tomorrow, if it's not mentioned, that we will be intentional about bringing it up, because we know Texas believes in prisons also. There were 3 things that folks brought up earlier, and I was over here saying they love gas, they love guns, they love prisons, and money. I was gonna say white people, but I didn't want to offend anybody in the room, but it's also true. And that's it. That's it, because you might not allow me back in the building tomorrow.
Hell yeah. Thank you all. I will say this, and we will recess. For those of you who joined us today online, I do hope you come back tomorrow. For those of you in the room, I do hope you come back tomorrow. As you can see and hear, and especially tomorrow, where we have an opportunity to turn these chairs around and talk directly to you, a real PACHA-to-the-People opportunity to engage. We really, as you can see, hear, and feel, want to be connected directly to you. That informs what we do and what we say and the advice we give. So with that, that's all I have for today. Vincent, do you have any closing comments? I think we are officially adjourned. Thank you all.
Produced by the U.S. Department of Health and Human Services.